This conference will now be recorded.
Okay, so welcome to the high-risk recurrent advanced prostate cancer meeting on the 10th of March, Tuesday. We have a couple of new gentlemen, and I will just read through the names that I see. First of all, Jake Hannum, Ken Anderson, Carl Foreman, David Muslin, David Winningham, Dennis McGuire, Jay Mills, John Hall, Les Shelderup, Sylvester Mann, Len Sierra. Did I miss anybody? Okay. Since we have a couple of new men, I should probably explain to the two gentlemen what we usually do. And I know I've told David Muslin this in an email, so he is a little bit prepared. So we'll let him go first. But we like to accord you time at the beginning of the meeting to tell us a little bit about yourselves, namely your disease demographics, where you are on the pathway, the treatment pathway, where you're being treated, how old you are, and if you have any specific questions. And then we open it up, and everybody will receive you and respond to you.
Hey, Richard, could I add one thing?
You may.
It's popped up a couple times, and it's for the new guys that come on the call. I think it's advantageous for you to kind of explain the recording and publishing process so that they know that the call because most guys don't know that when they come on the call, that one, it's recorded, two, it's posted to Facebook
Okay.
or to YouTube. So
Okay.
I think it's an important issue.
I got it. So yes, for those who have been on the call, I think you're all familiar with the fact that we record our calls and we tell you ahead of time. And what we usually do for the new guys is we send out a reminder. And I think David Muslin may have gotten that reminder, so he was aware ahead of time, because I had his email a couple of days before this meeting. But for David Winningham, I know you're not aware. We do record this meeting. If you do not want to be identified, that's just fine. But you need to let me know ahead of time. And so we can just leave your name off or in some way disguise your name, which we have done before. The reason we record the meeting is because there are people that cannot make the meetings. And so these meetings are all posted on YouTube and on our blog. So you can find the old meetings on our blog. And we have anywhere between about 20 and 40 hits each week, people that come in later on and listen to the meeting in their own time. So that's why we do that. And if you are concerned at all about your identity, and we've had people, in fact, there are people on this call who initially were concerned about that, then we just find a way to work around it. But we do not plan to stop recording the calls because they are, the recordings are of great use to a number of people. So how did I do, Ken? No, he's muted, so we can't.
You done good, Rick.
Sorry, Rick.
Yeah.
I'm on a call, so I'm listening though.
Oh, you're listening. Okay. All right. He's listening. He's on a call, but he's listening. Okay. All right. David Muslin, How do you feel about telling us a little bit about yourself?
I'm totally good with it and totally exposing my name and where I'm at, and I'm an open book, so I look forward to sharing with you guys.
Thank you.
Big time.
And let me just add that David was introduced to us through one of our favorite people, Jerry Deans, who was planning on joining us tonight, but he has his own meeting. So hopefully next week we'll hear from him. So I don't know how you, David, and Jerry connected, but any friend of Jerry's is a good friend of ours.
Yeah, so a gentleman in Chicago by the name of Peter Friend introduced me to Jerry.
Okay, I
Because
know
he sat on the board with Jerry.
Yep.
So Jerry and I, you want to hear my story?
Of course, we'd love
go
to hear
ahead?
your story. Please go ahead.
Okay. Jerry and I, by the way, we ended up spending about 2 hours on the phone yesterday. Our lives, lot of parallels in our lives, and so we had a lot to share. So I'm David Muslin. I'm 65 years old. I live in Chicago in the summertime and Florida in the wintertime. And I was diagnosed with prostate cancer in April of 17. I had a prostatectomy, and after the prostatectomy, the surgeon said the pathology report said it was out of margin, which I had never heard that term before. And I said, what the hell does that mean? He said, well, the tumor's outside the gland, and you probably have to do radiation and hormone treatment. So I started getting educated on that. Diagnosed in April of 17, prostatectomy June of 17, radiation in December of 17, and I decided not to go on Lupron. Let me back up and I'll tell you a little story. About 10 years before this, I had a resection on my colon done that had gone upside down and ended up with a bad infection. 3 months later, I had emergency surgery. Everything came apart, and they had to put me back together again. So I went through 2 major surgeries, and which is kind of what the connection I had with Jerry. And so I had worked really hard at rebuilding my body. A year after that second surgery, I did my first triathlon. I learned how to eat real well, became an athlete, and just rebuilt my body after going through hell. So for me, it was all about trying to stay healthy, trying to stay clear with as little drugs as I could. So I elected not to go on the Lupron when I did the radiation. PSA dropped to 0, and it slowly over 2 years ended up at 1.4. And in the meantime, I've been seeing a oncologist at Northwestern, medical oncologist at Northwestern University by the name of Maha Hussein, who's pretty well known.
Mm-hmm.
Jerry knew her pretty well, actually. And so as my PSA is rising, what do I do? And in between these 2 years, I did 2 PMSA scans and 2 Exuman scans. And the first PMSA scan that I did in July of 19, showed a couple tumors on some ribs, showed all kinds of crazy activity, she said, and I had broken my ribs several times. She said, don't worry about it. Let's just leave it lay. And you're not, you're doubling on your PSA trajectory every 6 months. Let's wait 6 months. We'll do it again and we'll see what happens. So I did another scan in January of this year, and a lot of the other noise went away, but the 2 tumors on the ribs got a little bit bigger and a little bit brighter. Very hard to do a biopsy on those ribs, but she's pretty comfortable that it's metastatic cancer at this point. And I just went on Lupron 3.5 weeks ago, 3 weeks ago today, actually. Maybe 4 weeks, I forgot. And that's kind of the story. So I'm out trying to get educated, and a lot of emotional feelings going on. Going to the stage of metastatic prostate cancer. That's kind of scary. And one doc says, "Well, you can live 10 more years." Another guy says, "I don't know how long you can live," but you hear all kinds of stories. So it was really great to talk to Jerry after. He's been doing this for 21 years. He started when he was 50. And so I'm thinking Maha Hussein, I just got on the Lupron. Got hit pretty hard this week with hot flashes, keeping me up at night. And but when I exercise hard and I go for a run or a good bike ride in the morning, it seems that these hot flashes seem to really die down.
Yeah.
And the big question that I asked Jerry yesterday was, on the path that I'm on, do I get a second opinion? Do I kind of just hang out with Maha Hussein? And we can talk more about that, but I don't want to take up everybody's time. But that's kind of the story at 10,000 feet, if you will.
So the exercise is definitely going to help you in any number of ways, David, and I'm sure that I'm only the first to tell you that. You'll hear that again from many of the guys. I suspected that back in 2007 when I was diagnosed, and the studies that have been done since then have really backed that up. And in fact, if you go to one of our other websites called MetaFit, there's a link to it under resources at the top of the AnCan page, and you go to the research page, you'll find loads of research articles about the importance of exercise when you're on hormone therapy. So when you've got a few minutes, you can do that. Some are actual clinical articles, some are just articles that have been written, but there are some good resources there. The one thing I would like to do and will do right after the meeting, it is actually on the website. You can find it under resources, but I'll send you a pamphlet that we wrote at UCSF introducing men to hormone therapy, because most doctors, even to this day, do not do a very good job when they first place men on hormone therapy. And we felt that was lacking, and we wrote a pamphlet. And the other thing is we recommend Richard Wassersug's Androgen Deprivation Therapy book. The pamphlet is free. You'll just download it. The book you can buy on Amazon, and if you're not already signed up to Amazon Smile, then you can sign up to Amazon Smile when you do that. So that helps us. Nominate us, and that helps us. But there is a host of experience here living with LHRH drugs. Are you getting, which LHRH drug are you on?
I don't know what an LHRH drug is, Rick.
Okay.
He said Lupron, Rick.
Oh, did he say Lupron? Okay,
Yeah.
Thanks.
Oh, Lupron, yeah.
LHRH drugs are the category of drugs that stop you producing testosterone.
Got it. Okay.
Luteinizing hormone. What's the rest of it, Len?
Releasing hormone.
Luteinizing.
Luteinizing hormone, releasing hormone. It's a little redundant, but that's what it is.
Okay, luteinizing hormone, releasing hormone. And they work in different ways, and they have different efficacy, but that's what it is. So what I would first like to do is just open it up a little bit and have a couple of men talk to you. You said you're 65 right now, correct?
Yes, sir.
So I'd like to have a few men talk to you about their experience on LHRH drugs, and we have all kinds of experience. We have some people that do exceptionally well. We have other people that don't do so well, and it's really very much different in every individual. So who would like to start? Peter, I think. Peter, but
You're
you have
muted,
to.
Peter.
You're muted.
Okay, David, I've got a question. This is Peter Kafka. I'm in Maui, Hawaii, and I've been on and off LHRH drugs for 6 years. Are you just on Lupron? Did Maha recommend a second line anti-androgen like Zytiga or anything else for you? Or are you just on Lupron?
Nothing. Just on Lupron. I took Caregivers for 10 days or 14 days before I got on where I got the 3-month Lupron shot.
Okay, I'm a little surprised with the history you've talked about and the spread and so forth. Nobody has suggested going to a second line anti-androgen. I mean, Lupron's the base. I mean, you'll be on Lupron on and off for a long time. But there are other drugs that have been proven to beyond, in addition to Lupron, second line drugs. And I've done several of them. A lot of guys on the call are doing them. Right now I'm on one called Nubequa or Darolutamide, and put out by Bayer.
Can you spell it, Peter?
Huh?
Can you spell it, Peter?
Nubequa. And I find it tolerable. I'm really delighted with it, actually. It's doing its job, but it's not giving me side effects at all. So, anyway,
and you're doing that.
Maha is one of the better people in the field, so you might talk to her, see, ask her about second line and whether it's fitting for you.
So, David, Nubequa is spelled Nubeqa, and its generic name is Darolutamide, Darolutamide, Darolutamide. It's made by Bayer, and we have 2 or 3 men that are on it. It takes a little sleight of hand sometimes by your medical oncologist to get it for you. Right now, anybody can get it for 2 to 3 months. Is it 2 months or 3 months, Peter? They give it you up front.
2 months.
2 months, and then it may take a little sleight of hand to be able to continue, because right now it's only approved if you're non-metastatic and castrate resistant, which you don't fit into either of those categories. But anyway, it is a very good drug. Who else would like to say a few words to David and give him some hope and lift his spirits on going on LHRH drugs?
Rick, let me ask a question. Did you say bicalutamide? Was it one of the drugs that was just mentioned?
No, but bicalutamide is a drug, is a first-line anti-androgen drug, and it's
Right.
generally used, and you probably took that for a couple of weeks, maybe 3 weeks before you started your LHRH, before you started your Lupron.
Yep.
And occasionally it can be used a second time around, and we're aware of that, because sometimes the androgen receptors mutate in a certain way that they may respond to bicalutamide later in the disease, but it's the exception rather than the rule that happens. So who else would like to speak to David about the LHRH journey?
I
I
can't.
can go ahead, Ken.
Yeah, I can add just a little bit because I've been on it for 3.5 years. I can honestly say the first 3 to 4 months were probably the only months where I really noticed it. And I noticed it with hot flashes, of course. Noticed it with a little bit of um, craziness as far as emotions are concerned, because again, they're cutting off the production of testosterone. So you pretty much go from like 60 to zero really pretty quick. And
Yeah,
for a guy, that's pretty difficult. But
yeah,
after a little while, it becomes kind of a normal situation. Um, and after the hot flashes, at least for me, they did disappear after 3 to 4 months. They were pretty
yeah,
intense first couple of weeks or month and a half, and then after that, they kind of started to subside. But I did
yeah.
notice really pretty quickly a decrease in muscle mass, both in my upper body and lower body. You know, at the time when I was first diagnosed, I wasn't paying attention to physical activity. And I do recommend, as Rick mentioned, get on some kind of a physical training regimen, both lower and upper body,
Yep.
because muscle mass deteriorates pretty quickly. So, but all
Were
in
you able to
all,
rebuild it? Were you able to rebuild that muscle tissue, Ken?
yeah, I did. I take pretty long hikes and mountain bike rides, and stretching is really important. So
Yeah,
find some routine to stretch out your back muscles and leg muscles, and I think you'll do fine. Most people, after a while, adjust to it pretty well. It's not pleasant, don't
yeah,
get me wrong, but it's necessary, one of those necessary evils. And I think
yeah,
for most guys, it's manageable after a while. Hope that helps,
yeah.
and by all means, send me a message if you need any or if I can help with anything else.
Thank you, Ken. Thank you.
Len?
Yeah, I guess Peter and Ken already said everything I would have said. So I guess what I have to say is just confirmation for what they said. Yet another opinion. Everything they said was also my experience. You do tend to tolerate the uh, androgen deprivation therapy better as you get into it more and more. Exercise is essential. Um, and hopefully you'll get to a point where Maha Hussein will let you go on intermittent therapy, although she's not one to favor intermittent therapy. If your PSA gets low enough, I would challenge her on that because it does give you a chance for your testosterone levels to come back and for your muscle tone to come back. Even if it's just maybe a 6 month break, any amount
Mhm.
could help. I also confirmed Peter's experience with darolutamide. When that was added to the Lupron for me, I found no difference whatsoever. It was as if I was taking a placebo as far as side effects are concerned, but it did drive the PSA down. So if by some magic you're able to convince Hussein to add darolutamide, if she can convince the insurers to give it to you, that's definitely worth pursuing.
So question for you: how does the darolutamide work with the Lupron? And you call that
Luke,
intermittent? I have two questions. What is intermittent therapy, and how does the darolutamide work with the Lupron? What does that do for us?
okay, so the Lupron lowers your testosterone levels, and the
Right?
darolutamide, and there are similar drugs to it, blocks the androgen or testosterone receptors in the prostate cancer cells. So it's attacking the cancer, or it's on two fronts. One, by depriving it of the level of testosterone, and then by whatever testosterone is remaining, it's blocking that from attaching to the receptors
Got
in
it.
the prostate
Got
cancer
it.
cell. Intermittent androgen deprivation therapy, intermittent hormone therapy, same thing.
Yeah.
means that after being on hormone therapy for some period of time, if you're responding well, you completely get off of it and you're drug free for some period of time, generally until your PSA starts rising again to a certain level
Yep.
determined by you and your doctor.
Yep.
And you take advantage of that time by, making an extra effort to build muscle mass and endurance and all that good stuff. And then, if necessary, you go back on the ADT drugs.
Got it. Got it. Yeah, she told me that 1 to 2 years she thinks I'll be on the Lupron for, is what she told me.
Okay.
Yeah, I mean that sounds about right. Initially, it makes sense to stay on initially at least 12 months to 24 months before even considering it, to give it a shot.
Yep.
One thing maybe we should explain is that there are the LHRH drugs largely act on the testosterone that's produced by the testicles. But there are other ways in which testosterone can get produced in the body. And so the androgen receptor blockers prevent the androgen receptors from sucking up any of the additional testosterone that is being produced. So it's sort of a
Got it.
double way. Now, there are some people, and really this is very unconventional and it really hasn't been proven, but there are people that will only do androgen receptor drugs. So they may have a significant amount of testosterone in their body, but they're just trying to block the receptors from getting to that testosterone. It hasn't been proven. It does have some benefits, has drawbacks too, but it's just another way of preventing the cancer from feeding on the testosterone. I will just say that just a couple extra words on the exercise. I was, and I still am, an endurance athlete, and always was an endurance athlete, and was very perturbed by the fact that when they put me on hormone therapy, which I did for 2.5 years, and able to stop after that. But when I was put on, there was absolutely no consideration for my exercise, and that bothered me. And so I tried to rectify that with some programs that we set up at UCSF. Now, just to give you some idea, I'm a sort of a skinny runner type of guy, and I could never build muscle. But when I started lifting weights, which I did avidly 3 times a week when I went on Lupron, I was actually lifting more than I've ever lifted at any time. So you can do it. And it's important to do it so you don't lose that muscle mass. And you as a, obviously as an endurance athlete as well, because you mentioned you do triathlons, try and mix in some weight resistance work with that as well. And if you do all of that, it'll help you. It will help you.
Thank you, Rick. The good news is I've been lifting weights 2 times a week, and have built a lot of muscle tissue over the last 10 years. So not a lot of muscle tissue, but I've got good. My body's full of muscle tissue, and I'm just continuing that regimen. So I'm a little ahead of the game there because I've got a good start, and I'm just continuing to do what I've always done.
Fantastic. Well, we'll support you in this. You'll come back regularly, and we'll keep supporting you, and you'll do great. I'm sure.
One last thing, Rick, that kind of popped into my head that I mentioned to John earlier, and that was, and John, correct me if I'm wrong. I think I mentioned it. I might not have. Um, that is to step up your appointments with your dentist, because of how the Lupron or these drugs work on
Yeah,
your bone. There's a connection with dental health.
yeah.
So if you only
Mhm.
go once a year, step it up to twice a year and just pay closer attention to your dentist.
And another question that you might put to Dr. Hussein is whether you should be on a bone strengthener or not. There are some doctors that will automatically put you on bone strengtheners. The advantage of these bone strengtheners is that they not only strengthen your bones and make it and make them less. They make them a little more brittle, but they make them denser. But they also make it harder for the cancer to grasp the bone.
Got
So
it.
there are doctors that will put you on bone strengtheners right away, and others who are not. I personally am in favor of them for myself, and I was
Yeah.
actually did a couple of questions. Did Dr. Hussein order a bone density test for you?
I do not know. She did not.
Okay, well, I would, for me, I would definitely ask her for one, because it's good to have as a baseline, if nothing else. Did
Right.
she order? Did she measure your testosterone level before you started the
Yes.
LHRH drug?
That she did. Yes.
Great. And what was that?
I don't know. I'd have to look it up. I don't know.
No worries. You'll tell us another time, but it's very helpful to know, because again, it gives you the baseline for when you come off the drug, so that you know whether you're getting back to where you were or you were not. And a lot of doctors won't do that, and we always, if we can get it in ahead of time, we like to suggest that you do that. But
Yeah.
I would probably, let me tell you why measuring your bone density is important. In my own case, I don't run anymore because I had a bicycle accident, but at the time that I was diagnosed, I was running a lot. And
Mm-hmm.
I never thought that I had any issues with bone density. It turned out I was borderline osteoporotic. You could have knocked me over with a feather. And as a result, I finished up getting bone density, bone strengthening drugs whilst I was on my Lupron. Not as regularly as if I had been clearly metastatic, but I did get them. So it's good to know your bone density, to measure it, just in case you've got any issues. And the doctors should do that if they're putting you on long-term hormone therapy.
Got it. So let me thank you for all this information, guys, and all the caring. Let me go on with my story a little bit. So I spoke to Hussein yesterday, who's a lovely human being. I think everybody knows that. And so I asked her, what do we do with these two tumors? I've got on my left side, I've got a tumor on rib 3 and rib 9. And she said, in 3 months after you've been on the Lupron, we'll do another bone scan. By the way, I did the PMSA and it showed the tumors on my ribs, but I did a regular bone scan and it didn't show anything, which didn't surprise her. So she said, in 3 months we'll do another bone scan and we'll talk about trying to radiate these tumors on my ribs.
Mm-hmm.
Any thoughts on that?
We have a lot of thoughts on that, but I'll tell you what, we need to move on right now. And we may finish up talking about spot radiation later on, but come back on Monday and we'll talk about spot radiation with you.
Great. Thank you so much for everybody's time.
Because it's not a short discussion. There are pros and cons. And if somebody else brings it up, you'll hear about it today. If not, we'll spend some time with you on spot radiation. But there are pros and cons around spot radiation. So save that one. Come back with us if you can join us online. We suggest that only because you can see the chat window and you can see Len's handsome face. So,
Hey, Rick, I just wanted to tell David that that's an important statement he just made, that his bone scan on the traditional bone scan was negative.
yeah,
That'll help you get the darolutamide.
Okay.
the big problem.
Even though it's for non-metastatic people, the standard is non-metastatic using the traditional bone scan.
Yeah, the big problem.
Yeah, so that's how I got it.
Yeah, the big problem for David is that we don't know that he's castrate resistant because he's only just gone on hormone therapy.
Right, that's the other problem.
Yeah.
Yep.
I wanted to also quickly bring up, because in listening to David, and he made a comment early on about whether he should go for a second opinion, and I'm all in favor for that. As those of you who have hear me talk in the past, because I live in New Jersey and I'm near several major cancer centers, I had 4 second opinions at all of these different centers before I decided on which one I wanted to have treated. So just to throw that out.
Yeah, I mean, I don't disagree. Personally, I don't disagree with you, Carl. And I think there are issues around a second opinion, such as what Peter raised. Would you use a second-line anti-androgen early? Would you add the hormone? Would you add a bone strengthener? At the same time, it's not David's case isn't anywhere near as complicated as yours was. And Maher Hussein is a great GU med-onc. So, that's sort of what, but yes, it wouldn't hurt. And frankly, David, if you were to get a second opinion, I would probably suggest either Walter Stadler down at UFC, because that's very convenient for you, or Chuck Ryan at University of Minnesota in Minneapolis.
Okay.
Those would be the 2 go-to guys that I would suggest from where you are. I mean, there are other very good GU med-oncs in Northwestern, but you can't really use them because you're already at Northwestern with Maher Hussein.
Right. Okay. Very good, gentlemen. Thank you so much.
Anybody else before we leave David Muslim?
Did we get a Gleason score from David?
Oh,
We did that. My Gleason score was 4+3.
okay. Thank you. Thanks, Len.
Yeah.
And what was your PSA? What was your PSA when you were diagnosed?
It was about 4.5 or so.
Okay.
For that quick a metastatic spread with a Gleason 7, even unfavorable 7, I would do I would ask Maha to do a genetic sequencing. Maybe something else going on there.
Well, yes, but do you want to burn that so early until we know that you can get repeats, unless you can get it done in Northwestern? And there's and the other issue is that the PSA was never that high either. So there may be something going on. But again, David, we don't want to burden you too much this first time around. We have a lot of knowledge in this group, and we don't want to overwhelm you. But if you keep coming back, we'll find things we talk about. And if you decide to go for a second opinion, We'll also help you create a list of questions. And we'll help you
promise
create.
you guys I'll be back. This is amazing.
Yeah, well, we can help you create a list of questions from Maha Hussein as well. All right, let's get to David Winningham before anyone else jumps in. And now you know the program, Mr. Winningham.
I think so. I am 73 years old. I was originally diagnosed late of 2011. Was put on Eligard. About my PSA went from, in 1 year, went from 4 to 21. And I was put on Eligard for 2 years and had radiation treatment, 42, if my memory serves me right. Did not have surgery because they'd already gotten out of the cavity. They said that would not be, there'd be no reason to do that. So, and I remained at zero from 2013, excuse me, end of 2012, I guess, until I did my regular 6-month checkups. And curiously, in January of 19, I was having a regular checkup, which included a regular CT scan, and we discovered that I had kidney cancer. And they had said that they didn't believe there was any connection between the two. They removed that kidney, and then in July or August of 19, came back for a regular checkup, checked my PSA, and it had gotten high again, higher, and ordered a scan, and it was clear in terms of organs, but they thought they noticed something maybe on the bones. So in November, I had a bone scan, which showed that it had metastasized considerably in about 8 or 9 spots throughout my skeleton. That point was assigned to, went to, for the first time, I'd just been seeing my urologist up until this point. Went to an oncologist and was put on, in January, was put on Xtandi and Xgeva, and moved and started Lupron. Actually, I'm sorry, I started Lupron back in the summer of 19. So I've been on it back, instead of Eligard, I moved to the Lupron, the 6-month dose, but I'm now being moved to the quarterly dose of that.
Mm-hmm.
I don't think I'm leaving anything out there. Yeah.
Okay. And where are you where do you live? Where are you
I'm sorry. Yeah, I live in Nashville, Tennessee, being treated by Dr. Patrick Murphy at Tennessee Oncology.
And is Dr. Murphy a specialized genitourinary medical oncologist, or is he a general oncologist?
That's a great question. I believe he's a general oncologist.
Right. Well, we have another Tennessean on the line who's exceptionally familiar with resources in Tennessee and elsewhere, and we'll let him talk to you momentarily. But one of the things that we strongly recommend, if your insurance permits, is that you put yourself in the care of a genitourinary medical oncologist. The genitourinary medical oncologists specialize in cancers of the genitourinary tract, which may well include kidneys. That is kidney cancer, bladder cancer, prostate cancer, testicular cancer, and I'm probably missing some things out. But what we find is that the general oncologists just don't keep up well enough with the field, and there's so much going on. At the same time, to put you on the Xgeva and Xtandi is certainly a good move. And I'm not sure anybody else would have treated you that differently. But from the standpoint of having a quarterback, in the long run to guide your care, it would really serve you very well.
Okay.
To do that. Jay, would you like to say a few words to your fellow state person?
Sure. Can you hear me?
I
Yes.
can.
Okay, I'm in a grocery store. I'm in Chattanooga, and
Okay.
my case is 2 years ago diagnosed with Gleason 8 and PSA of a high about 35, and I've been 2 years on ADT, and I had high dose radiation to the prostate, then IMRT, and a suspicious spot on a rib was had spot radiation SBRT. I'm about 21, almost 22 months into ADT out of 24, so I'll soon go off my PSAs down to 0.02. And I also was on abiraterone for a short while, well, 6 months as well. And in terms of doctors I'm seeing a general med-onc as well, a Ted Aerosmith in Chattanooga, who is supervising my ADT and just a general advising me. I've also visited other med-oncs, and before I had treatment and during my treatment, GU med-oncs, who have sort of been people I could run things by, and there are, I think the most recent one was at Johns Hopkins, Antanerakis, he's a Greek origin, and he's the most recent one I've visited, and it's not too far away. In terms of, I don't know the group you're with, but in being in Nashville, I'm sure there are several GU med-oncs up there at Vanderbilt, probably.
Probably, yeah, I would think so.
Maybe not. So there was a wonderful GU med-onc at Vanderbilt, and she recently left about 2 years ago, and she went over to Northwestern. There is one guy there, but I think we've gotten sort of mixed reports about him. I want to say, and I could be totally wrong on this, but I want to say his name is David Smith, but I may be confusing him with Emory. I'm not sure, but you may need to go further afield, and what many people have done, and Peter can talk to you a little bit about this, or Ken Anderson can talk to you, is that they will find a quarterback GU med-onc at a center of excellence who works with a local doctor.
Yeah.
And so you combine the two. Now you have to have a local doctor who's willing to do that.
Yeah.
And egos are fragile.
Yeah.
Sure, I don't need to remind you about that.
Right.
But let me throw it open to other people on the line to contribute on that.
This is Jay again. There's one person that's within reach, I think, would be driving distance from Nashville, would be Oliver Sartor at Tulane.
Yes.
How do you spell that last name?
And Sartor, no E.
Good question. Yeah.
And he was, for a short while, he was in the same position that Sweeney now holds at Harvard's, it's the hospital at the Dana-Farber.
Right.
And he was in that position. I visited with Sartor, and he's brilliant and very much at the leading edge of all this research that's going on, all the new stuff that's going on. He's does a lot of good genetic stuff too. That he'd be good to work with. Have you had your core samples analyzed genetically yet to see what's going on there and what's your?
I have. Yeah. I mean, I was.
Okay. Yeah.
Yeah.
Okay. Anyway, Sartor would be somebody and you can look him up online. He's a good speaker, and you can see him online and see how he thinks.
Okay. Thank you.
Yeah, I mean that's a really, really good suggestion. I have a young doctor friend who was one of his students and always spoke very highly of him, and he's likely to know who would and would not work with him in the Nashville area too. So I think that's an excellent suggestion. Yes. Who wanted to speak?
What did you say your Gleason score was, David?
It was 7, 4 and 3.
4 and 3. And you got 9 years out of your first treatment. I mean, that's really good. I mean, I think that's a great track record, actually. So I wouldn't be. I mean, yes, you've got some metastatic spread, but I wouldn't freak out at this point. I mean, I think the disease is manageable. I don't think it's going to go in. It doesn't seem like it's going to go into a tailspin. If you've gotten 9 years out of your first primary treatment, there's a lot of things you can do at this point, and you'll probably keep going for a long time.
Well, I'm not sure what you meant by. I mean, I've got sizable metastases in ribs, in my femur, in my humerus,
Right.
and lesser amounts in my spine. But
right,
yeah.
but there are drugs that can help manage that. And if it doesn't, this might not. As long as you stay on top of it, it's probably not going to run away from you right away.
Yeah.
It can be managed. There's guys on this call have chemo and this and that, and have breasts, and they just keep going on.
Yeah.
Life goes on, and it's not the end game for them.
Right. Well, one of the bigger issues of me, and I don't know if nobody else has mentioned it, but maybe because I'm just joining the group, but the expense of this is pretty extraordinary. I'm on Medicare with a supplement Part D, and it's running me $4,000 a month.
Whoa.
For what? Lupron?
Pardon me?
Lupron and Xtandi.
And Xgeva. Yeah.
And Xgeva.
Medicare should cover Xtandi if you've got a supplemental plan.
I'm sorry, I didn't understand.
Medicare should cover it. If not, we can find another drug that's will do the same thing.
Yeah, we have looked at another drug called Xgeva to take the place of the Xtandi, which is conservative less, but
Zytiga.
Yeah, Zytiga. I'm sorry. Yeah, Zytiga. I'm sorry. But even with that, you're still looking at cheapers. I don't know. But it's going to cut $1,000 off probably. But it's extraordinarily expensive.
You can call up the drug companies themselves.
Yep, I applied to the Xtandi people. They declined me.
Okay, well try the Zytiga people. They're a little more amenable.
Okay.
They helped me out quite a bit, and I had it down to 10 a month.
Okay. Will do.
Well, more than that. First of all, I mean, my understanding is that once you go through the donut hole, which you should go through pretty quickly, it's going to drop significantly.
That's true. Yeah.
Okay, so yes, you may be paying $4,500 very quickly, as you have done, but now it's going to fall dramatically.
Yeah. looking
It's not
forward
going
to
to be 4,000 a month.
I'm looking forward to that. Yeah.
Right. But we're not looking, you're not going to be looking at $4,000 a month, David.
Right.
There are a number of places where that you can apply for drug support. The Patient Assistance Network is one of them, PAN, and there are a number of others. I keep planning to do a blog post on this, but I haven't done it yet. But I can help.
Yeah, PAN says they're not currently accepting applications for the prostate cancer. Yeah.
So, yeah, I mean, and this is the thing, you have to find out who is and who is not. You can talk to Zero, you can talk to us too, because they're more on top of who's doing it than I am. I just don't have the time. I sort of learn very much from what I hear reported on here, and I don't know if anybody's been applying this year, but we've had a number of people that have applied and have been successful. The one thing I do want to talk to you about, and this is the discussion that you would really have with somebody like a Sartor or another good GU med onc. Chuck Ryan in Minneapolis might be accessible to you, or one of the Chicago doctors. The research seems to say, you're not going to want to hear me say this, but I want to tell you so you can explore it. The research seems to say that when you have more high volume disease, that you're better off doing chemotherapy early.
Okay.
And rather than doing a second-line anti-androgen like abiraterone, Zytiga, or enzalutamide, which is Xtandi, first, do the chemo first, because that has more legs and seems to give you better overall survival. Len, you're better than I am on remembering the sources of the studies and what have you. Can you talk to David a little bit about this, or if not you, somebody else?
Yeah, there's a few drug trials that they did, Stampede and Charted and Latitude, and I tend to get a little confused myself. I think Charted was the one that suggested it was good to, if you had high volume disease, you go ahead with chemotherapy rather than hormone therapy. Now, those are newly diagnosed patients. I'm not sure how much that applies to you, since you were diagnosed many years ago. Even though you now have high volume disease, you didn't at first. So, you know, it's very difficult to find clinical trials that match you perfectly. It almost never happens because there's so many variations in people's conditions. But yeah, what Rick is talking about is the Charted study. High volume disease, chemotherapy proved to be more appropriate. Whether that applies to you because you're not newly diagnosed, I couldn't say.
Yeah, my oncologist and I, the first time we met, maybe it was the second time, but I believe it was the first time we met. There was in his mind, it was a question of, do we do chemo first or not? And after doing the genetic study, he decided, no, let's don't do the chemo first. Let's do this first. So I don't know if that makes any sense.
No, it does, and a couple of points on that. When you say the genetic study, was this a test for inherited mutations? For inherited mutations.
Yep. And my mother had died of breast cancer. And so he said, let's go. This would be, so that's interesting. And I want to take a look at that. Sort of prompted him to look at my genetic.
Very good. So, and did it tell anything?
It did not tell him anything. No.
Okay. So, you know, one of the other things, but again, it might be a little early. And the question that was asked to you before by Peter is that we can also sequence your tumor. So that would be for mutations that you have developed as opposed to mutations that you've inherited. We call those somatic mutations. It may be a little early to do that for you. Do we know how you're responding? Let's see, you mentioned your PSA started to go up in January of 19. How high did it get by August of 19?
11 in August of 19 and 19 in December of 19.
Okay, and what is it? Do we know what it is now? What's your most recent?
You know, I don't know. The December one's the last one I know.
Okay, so again, this is another point, and there's a lot of controversy over this, but probably good to be testing more regularly, especially when you go on Xtandi, because there are certain mutations that might mean you don't respond to the Xtandi, and we want to be on top of that. So it's always good when you're on Xtandi or abiraterone to test monthly when you start on it, so that you get a feel for whether it's working or it isn't working.
Okay.
And then if it's not working, you can be nimble and switch to something else. And then, whether you would want, you do get a subsidized, highly subsidized genetic test of your tumor. They would have to do a biopsy, probably from your humerus or your femur. It's not it's not a difficult process. Many of the guys on this call have done it. But right now, you only get one in a lifetime, although that has been contested, and it may be that it's changed. It's not clear to us just yet whether it's changed or it hasn't. So I can't say to you, but what I don't want you to do is to burn it now when you might need it 2 or 3 years from now. On the other hand, if you can keep putting it in repeat, and what we're saying to Medicare is, guys, in prostate cancer, these mutations change as the disease develops. And so we need more than one, and they're listening, but we're not there yet. But again, it's something to discuss with a good GU med onc, and I definitely would want to get tested to see if your PSA is responding, and probably to get scanned again, maybe six to 9 months after. If it were me, I'd want to get scanned 6 to 9 months after I'd started the Xtandi, if the Xtandi was working, if it's bringing down your PSA, and to have this.
When you say scan, you talk about what kind of scan? Bone scan?
Both a bone and a CT scan. And
that's scheduled. That is scheduled for 6 months.
Okay, excellent. And then I want to direct you to a conversation that between 3 very good GU oncologists, medical oncologists: Alicia Morgans, who was at Vanderbilt and is now at Northwestern; Chuck Ryan, who we've mentioned, who's in Minneapolis; and Chris Sweeney, who was also briefly mentioned by Jay earlier on. And this is probably now about 8 or 9 months old. I'm going to put it in the chat window for you. And it comes off of our website. You can find it under resources on our on prostate cancer resources on our website. But they discuss the pros and cons of whether you go with chemotherapy first or whether you go with a second-line anti-androgen as you have done first. So I've just put that in the in the chat window for you.
Okay.
And you'll find it on the website. I do want to get around everybody. So is there anyone else? We've given David a lot to think about. David, you we don't have your email. If you would like to be placed on our list so that we send you a reminder before each meeting and whatever else we talk about in the reminder letters, and there's different things, we're happy to do that. You can send it to me directly on the chat window. You can send it to rd@ancan.org. R as in Rick, D as in Davis, rd@ancan.org. Or you can go to our website, ancan.org, and you can sign up yourself directly.
Okay.
But we'd like to keep talking to you and navigating you the best we can and support you.
It. Yeah, thank you.
Okay. Anyone else want, before we move on, anybody else want to say anything else to David? Okay. I've added a couple of extra names who arrived since the original time that I did the roll call. So let me go down and see who would like some time today. We have about 45 minutes. We do need to finish pretty promptly today because, as I mentioned, we've got a board meeting starting a half hour after this. And so I have to gather my thoughts, if nothing else. Jake.
No, I'm sorry. Is this a 2 hour? I was thinking it was a 1 hour session.
2 hours.
It's 2 hours. Unfortunately, I'm going to have to bail off because I had planned for an hour.
That's okay.
Yep.
So, yeah, I mean, usually what happens is we receive the new men up front, and then we go around and ask anybody who.
Okay.
But you can listen to the second hour on YouTube or through our through our blog.
Will do.
Okay.
Thank you.
Okay. Take care, David.
Yep.
My notice said it started at 7 p.m. Eastern tonight.
6 p.m. Eastern.
Yeah, I'm gonna say I just read my notice again on my email, and I'm looking at it again. It starts at 7 p.m. Eastern, but whatever.
Oh, well, that was that my mistake, gents?
I don't know. It was from AnCan, the day before I get a notice on the meetings.
It was probably my error. Let's just see here. Here it is. No, 6 p.m. Eastern.
I don't know what happened with mine because I'm looking at it.
Unless it was in the. No, I've got it here. 6 p.m. Eastern in the title and 6 p.m. Eastern in the.
Never mind. It's my fault.
It's not been unknown that I make errors when I send out in time. Is that right?
I never do, but I just did. That's the other meeting on Wednesday, the 12th.
Yes. No, Wednesday, Thursday. The Thursday meeting is 7 p.m.
Yeah.
Okay.
Yep.
All right. Jake, would you like some time?
No, thank you.
Okay. Ken, would you like some time? You said you had an update, so yes. You're muted.
I know, yeah, I can. But I don't have a lot of the information. I don't have my CT scan, but I can give you a little bit on PSA.
Okay. All right. Carl, would you like some time?
Yes, not a lot.
Okay. Dennis McGuire, would you like some time tonight?
No update. Thanks, Rick.
Thank you. Jay Mills, anything for you tonight?
Negative. Nothing tonight.
And thank you for talking to David Winningham. I'll connect you guys when I get his email.
That'd be great. Thank you.
John Hall, I think you have some, you'd like to talk to us tonight. John? So we see your microphone and it shows green, but we don't hear you. Not sure. Oh, now you turn the microphone off. Turn your microphone on again. and say something, and I still think we don't hear you. So maybe your mic isn't working. You may have to call in. It sounds like your microphone isn't working. But I'm putting you down for some time, so you have time to sort. You have a little bit of time to sort that out. Les, anything for you tonight?
Not tonight, thank you.
Sylvester, anything for you tonight?
No, thank you very much.
Okay. Leonardo, anything for you tonight?
Niente, Rick.
Okay. Peter, anything for you?
Yeah.
Niet. Okay. And Russ Smith, anything for you tonight?
Just a quick update, nothing long.
Okay, and then we have somebody, whoever is coming on as owner, we welcome you.
That's me, Rick. It's Dennis Correa.
Oh, it's Dennis Correa.
I had a problem trying to get into the meeting tonight, and so I rushed to download the app again, and maybe I missed the place where I put my name in there. So I see it's up there as owner. I'll fix that later, but that's owner is me.
Because we had somebody else as owner last week, and it was confusing the heck out of us.
Yeah, I'll fix it. I don't need any time.
Oh, and you don't need any time. Okay. All right. So let's kick off with Ken Anderson.
All right. Well, I had my labs Monday. I don't know what day it was. Seems like it wasn't too long ago. Maybe on the 6th, I had the labs. I got the report back, and my PSA has gone up again, which I kind of anticipated. It's moved from like 8.9 to 12.9. So, I'm not too optimistic that this AR drug, abiraterone, is going to work for me, but I need to give it another 3 weeks, I guess. It's only started on the 26th. So I'm going to give it another 30 days, see how high my PSA goes. Any thoughts on that? Either jump off and start chemo. I'm going to put a note to Paul at MD Anderson and see what his thoughts are. But the CT scan, I don't know yet. I had the CT scan on Monday and I don't have the results back. But quite honestly, I'm not anticipating anything, but who knows? Maybe something will show up on it. So I usually do produce a lot of PSA. When I first got diagnosed, I was in the 500s, and the next month I was in the 700s. So I honestly don't know. Maybe the CT scan will show something. Maybe it won't.
Well, it's puzzling to me because you didn't respond to the enzalutamide. Doesn't seem like you're responding to the abiraterone, but
enzalutamide, I did respond for like 30 days, cut it in half.
Yeah.
But then shortly thereafter, it stopped working. So is there something in the AR pathway that's not going to work for me? I don't know. It's a question for Paul and Logo at MD Anderson. I don't know. My medical oncologist locally doesn't know. She at the moment doesn't know.
Right. So there are people that take time to respond to abiraterone, and I'm thinking that might be your case, but I can't think of too many better people than Paul Korn to try and figure out this conundrum. What about people on this call? Anybody have any ideas?
I had I had Zytiga flare, as my doctor referred to it, when I first started taking it. For the first 2 months, Ken, my PSA went up before it started going down, for what that's worth.
Yeah, I know. I've only been on it about a week and 3 days, so I doubt very much that it would even show up on this most recent PSA. I mean, all my other stuff was fine. Glucose was low, white blood count was low. There was really nothing on my labs. And I met with my GP today, and we reviewed everything, and he said everything looked fine. And I keep the metformin and the Crestor, and right now I take 400 milligrams of magnesium for my cramps in the legs. And if I miss it one day, I notice it. That evening when I go to bed, I have severe cramps. So whatever magnesium does, it works for me for cramps. Yeah, I just don't know. I mean, I would imagine Paul's going to say, give it a 4-week try, as he said in an email in the past. See what happens at the end of, um, or like the first of next month, and see where I'm at. So,
I would give it even longer than that, Ken. Give it at least 2 months. My
I
doctor
just,
says 3, but that's probably too much if it's not responding at all. But at least give it a 2 month.
Yeah,
gotcha.
yeah, and I'm not even sure I would. I mean, I didn't focus on how that you've only been on it for a week and a half. I should have remembered, but I didn't. But I wouldn't even bother full corn at this point.
Yet. Yeah. I was thinking the same. Unless, I can't get a PET scan here locally because the CT doesn't show any. The only way my insurance company will pay for the PET is if the CT shows that it's advanced. If there's more Mets, then I don't know what they're comparing it to other than when I was first diagnosed, because every scan after that's been a PET scan at MD Anderson. So apparently, how MD Anderson packages their billing, it's hidden within their packaging from the institution because they never send out a delineated bill showing all the miscellaneous charges. They just put it all in one lump sum and they get paid, and I never give it a thought. But here locally, it's been an issue. Apparently, it's not approved by the FDA for prostate cancer. Is that a true statement? The PET scan's not approved?
No, it is approved. Different. I mean, it depends on. Depends on the contrast for the PET scan. There are different contrasts, but it's definitely approved.
Right.
I mean, I don't know
PYL is
why.
not approved, but
I don't know
Examen
why.
is.
Oh, I don't know why the letter from my Blue Cross Blue Shield would state, but it did state they have to prove, disease advancement or something. PET scan's not approved for prostate cancer without the disease advancement or something like that. And they denied me. I actually appealed it and they denied it a second time. So I said, hell, just do the CT scan, even though it's a crappy 20-year-old scan. Just do the bloody thing and I'll get a PET scan later. So I don't know. I didn't want to fight with them.
What kind of PET scan do you want to give you, Ken? You know what it
Um,
Is it sodium fluoride?
it is. Yeah.
Yeah.
That's
Yeah,
approved.
I've heard they're starting to balk at reimbursing for that from my doctor, Dr. O.
Oh.
Apparently, they don't feel it's very effective or sensitive, or maybe there's too many false positives. I don't know.
It's a very old scan.
Yeah.
Well, we'll see. You guys can move along. I know what my PSA is, and I feel good. That whole comment about, you look good. It's like, I know I look good, but I've had 8 months of PSA rise for criminy sakes.
Ken, it wasn't, maybe we've talked about it recently. Wasn't there a recent European study talking about cabazitaxel and was failure of those drugs, and it was found pretty effective for guys.
The card trial, yeah, the card trial. I think Lynn brought it up a couple of times for guys that failed second line drugs. I'm kind of bat.
Well, keep it in your back pocket. Keep it in your
I
back.
have it. I have it as could be my next thing going every 3 weeks. Cabazitaxel, Jevtana. I think that's probably, but I might give it 2 months. I don't know. I think when I get my next PSA, when it goes to like 20, I'll be ready for chemo.
Ken, didn't you tell me one time on the phone that you saw a study somewhere that chemo resensitizes you to the anti-androgens that no longer work?
It was not a study. It was a comment from Alan Adele
Oh, okay.
on one of his posts on Health Unlocked. that he thought it was possible
Oh,
that it resensitizes the AR, pathway. But I haven't seen anything in a clinical trial or anything, no.
okay.
But it is worth discussing with these GU medoncs, and I've heard that before, and I'm sure that's where Alan got it from attending an appointment. But yeah, I mean, I think the biggest takeaway from this, Ken, is that you've got to give abiraterone more than a week and a bit to see if it's working for you.
No, I know that. I
And
know that's why I'm not too mental yet.
the 12.9 is really a reflection of the enzalutamide and not the abiraterone.
Well, it's a reflection of Lupron and Firmagon, which I bloody hate in my stomach. I just absolutely hate it. I get a rash and it's right at my belt line, and it's like, if it doesn't work for me, put me back on Lupron. So give me a 3-month shot,
What's giving you a rash, Ken?
The Firmagon.
Oh, yeah, that's typical.
Yeah. So I got a shot like on the 6th. Today's the 10th, and I still have a rash and it's sensitive there. So,
Well, you know what? There was a study done that showed abiraterone alone kept T levels down as well as abiraterone plus Firmagon or abiraterone plus Lupron. It might have been Lupron, or doesn't matter. Being that Zytiga or abiraterone suppresses T levels from the everywhere, no matter where it's being produced, right? So you might be just as well off just on Zytiga.
Right. Well, I noticed I get hot flashes again. Like right now, I'm having one. So it's doing something that Lupron stopped doing. So they're not as frequent as when I first went on Lupron. But I don't like Firmagon. I don't like it in the belly, I guess. It's right at my belt line, and it's a rash. And if there was one thing I had to complain about, that would be it today.
What do you have against Lupron?
What's that, Jake?
What do you have against Lupron?
Well, I think there was an attempt by Paul to see if switching Lupron to Firmagon would give a benefit. I don't know. Maybe it might have been just some little ploy to get me to stop, think that I was getting some different treatment. So it might make me mentally not as crazy. I don't know. Paul knows me pretty well.
I love the way you describe yourself.
I'd like to keep talking, but
No, move along. We're good.
We've got 3 guys and we've got 30 minutes, so we've got 10 minutes. We've got 10 minutes a person, which should be fine for us. We can always come back to Ken at the end. So Carl Foreman, you are up.
Okay. Just as a follow-up of 2 items I previously discussed, one of which was concerning the scan that I brought to everyone's attention, and I appreciate everyone's input, and I did request that it's time for me to have an updated scan. I'm looking to have the Aximum PET scan. I got the script from my oncologist, and now we're just waiting for Aetna. They had an initial denial. I heard that this morning, and then I expect that it will get approved pretty shortly on. I hope so. So that's one update. The second update is relating to I was told that my creatinine levels were somewhat elevated, which is possible evidence of some kidney malfunction. And I did follow up with a nephrologist who I hadn't seen in a couple of years, and he did an updated blood test as well as 2 different urine tests, one a cytology urine test, which I saw him a little while ago, about a couple hours ago. He explained about the cytology is the one that where they look under the microscope and they look for any unusual cells, potentially cancerous cells, and it was clear. And my creatinine levels are back within normal range, and what I did was I started drinking more water. So that was the magic magic for that. The next item is relating to coronavirus, which is on the news every 5 minutes, and we haven't had any real discussion about that. But I was curious to ask my oncologist, do I technically have a compromised immune system where I have to be more concerned? Now, I haven't had any chemotherapy. I'm on PARP inhibitor, olaparib, and Eligard, and a couple other things. So he responded back to me that no, in general, but realized that this virus is like a flu, spreads with cough. You should avoid touching your face and wash your hands. So he's telling me the same thing that everyone is telling. And I also said, well, I have a cruise booked in June. should I consider canceling? And he also said, logically, he said, well, it's too early to tell. But I was curious to throw it out to everyone. Don't we all have a compromised immune system because we're all being treated for advanced prostate cancer? But my particular oncologist, for me, said that I don't have that.
Now, which oncologist was this? Your guy at New Jersey Institute?
Yes, Dr. Soraya. Yeah.
Soraya. All right. Discuss. You know, does everybody being treated for advanced prostate cancer have a compromised immune system? Discuss.
I believe so. Particularly olaparib, which you're taking, is known to suppress the immune system, drive your white blood cells and platelets down. Do you know what your blood cell counts are?
Well, I know I'm borderline anemic, so it's at the low ends.
Yeah. Well, your blood cells are produced in your bone marrow, and the immune cells are also produced in the bone marrow. So you no doubt have some measure of immunosuppression. Just by the olaparib alone, plus the Lupron is additive to that. If you were listening to Anthony Fauci, he said no cruises. He said no cruises for anybody. So whether you're healthy or not. So
anybody over 60, I think he said.
I don't know about that. I'm pretty sure he told everyone to stop taking cruises. But anyway, you're over 60, right? So
yes. Yeah. And I also did have immunotherapy. I had Provenge, but that I don't think that matters at this point.
No.
I can add, MD Anderson, their CEO, recently did it yet today. He posted a short video online stating any of the patients at MD Anderson that have cancer have compromised immune systems and they should take precautions. So, and that was to everyone, prostate cancer, all cancers. So
I canceled my cruise today, which would be July, on my doctor. But I also work in the medical field. Had an update today by our chief medical officer and the CDC, saying this is being blown way out of proportion for normal people. But my doctor said anyone, in our stage should be overly cautious, not just with the coronavirus, but with everything.
Another drug that affects it is prednisone. That reduces your immunity. And I think any corticosteroid, so that may include some of the stuff you take for like cholesterol. That'll also reduce your immunity.
Ah.
Carl, if we can put off the trip, put it off. That's my 2 cents.
Yeah, I mean, it's going to be Royal Caribbean, and they did announce, like, I think all of the cruise lines that up to 48 hours prior to departure, you can cancel without penalties. So I'm going to let it ride as long as I need to. But yes, I am concerned, and I probably won't end up going, but we'll see.
Carl, I called today, and the coronavirus in itself is not enough to cancel, at least on my cruise line. I was doing an Alaskan cruise in July. But when you have cancer and treatment thrown in, they don't question it. You just may need a doctor, to give you a letter, but that's it.
Okay.
This is Jay. I had a couple comments on the coronavirus. It attacks the lungs, causes inflammation, and then if the inflammation gets bad enough, you get to where you can't breathe, and you start starving of oxygen, other organs of oxygen, and you have multi-organs involved with inflammation and failure. So oxygen carrying is really important, and yet first thing that happened when I went on ADT was that my red blood cell count dropped subnormal, and it stayed that way pretty much. If I exercise really hard, I can get it up barely into normal. But anyway, that's a challenge for all of us perhaps that are on ADT. I don't know. The other is that people a lot of the word coming out of Iran and then out of China is that people are actually having the severity oscillates, and they'll feel like they're getting better, that they're healing, and then it will double down and kill them. And like is often with influenza, it's called a cytokine, I think it's called, storm. It's where your immune system is taking over, is suppressing the virus, and then the virus ramps up to overcome it, and then you have this battle that destroys the host. And so you can have too strong of an immune system. One of the things is that androgens are actually immunosuppressive, and so if you have a compromised immune system, you might not be able to fight the virus either. So it's a double-edged sword. You could have too strong of an immune response or not enough. Both are. We don't know the disease well enough, I guess. That's all I had to say.
Okay. I'm not sure I really want to wade in on to this one, but the only thing I do have to say is just bear in mind that influenza and viral pneumonia are killers. 20,000 to 60,000 people every year in this country. I guess it varies from year to year. What I really cannot get my arms around is some hard numbers as to how this COVID-19 really compares in the long run, and maybe because there is no long run, to the mortality from those diseases. And personally, this is just my view. I'm not 100% convinced that it's significantly worse than the other diseases, but we seem to have latched onto it, and the world believes it is on a macro level. So those are my comments, and I'm going to move, and we can come back to it, but I want to make sure I have enough time for everybody.
Yep, thank you.
John Hall, who is now with.
Can you hear me now?
And we can hear you now. I don't know. It must have been something with your mic there, John.
No, I went to my cell phone.
Oh, okay. So why don't you give us I'm delighted that you and Ken got together today. And why don't you give us a quick update on where you are this week?
So I saw my urologist and radiation oncologist for the first time since the biopsy, and as to be expected, they sort of had different treatment plans. The urologist wanting to do prostate cancer surgery, and the urologist wanting to do SBRT radiation therapy with Lupron, and followed by radiation oncology. And tomorrow I meet with a medical oncologist, and so I was wanting feedback on
currently I'm getting an MRI on Thursday, but it doesn't appear that it's metastasized outside of the prostate. So I wanted to get feedback on radiation therapy versus prostate surgery for my stage. I'm Gleason 9.
So my first question to you is, did you get the email that I sent you this morning?
Yes, I did, and I've downloaded all of it, and I've been reading through it. I've been reading dozens of different clinical studies.
And the second, hold on a second. The second question is, did you run the nomogram on the Memorial Sloan Kettering nomogram?
Not yet.
Okay. Well, that's really what I wanted you to do for this meeting, because the big concern that I have personally with the sort of high-risk disease that you're looking at is that the likelihood of nailing the disease from surgery alone is very slim. In my own case, the nomogram said I had a 30% chance. In your case, I suspect it's going to be even lower. On the one hand, you're a little older than I was at diagnosis, but on the other hand, you have a 4+5, I had a 4+4, and you have a lot more cancer. So my guess is, and I'm just guessing, that you're probably going to be somewhere around 15%. And then the question for you is, do you want to go through all the comorbidities of surgery and then have to do the radiation and the hormone therapy anyway? And what is the advantage to you, the marginal benefit to you of doing that? Is there one? And the answer to that is we really don't know. There's really never been any studies done. So the best you can do is ask educated folks. So one of the big questions that you need to ask the medical oncologist tomorrow is, if you were going to do radiation and hormone therapy and you decided to add to that surgery, what does he think the benefit of that surgery would be for you? And Peter Carroll, who I usually quote because he's well known and very well respected and is the chair of the urological oncology group at UCSF, he thinks it's in the region of 3 to 4%, and that's normally the number that we hear. Now, for some people,
can you repeat what that 3 or 4% represents?
It represents the additional benefit in terms of the disease being nailed at this early stage if you add a radical prostatectomy to hormone therapy and radiation. Did you follow that, or would you like me to repeat it?
Yes, I do. Yes, I do. And
okay.
I'm very good at statistics.
It's very, very subjective, John. We really don't know. But generally, those are the numbers that the best docs seem to throw out. That there is benefit from doing a radical prostatectomy over and above, but it's not a huge benefit. Now, the question for you is, well, is that 3 or 4% worth the extra comorbidities, side effects that I am going to suffer from the surgery? Because there will be. First of all, you cannot get away from the fact that you will be incontinent for a period of time, hopefully no more than 30 days, but maybe a lot longer. We don't know. Secondly, there are going to be issues around erectile dysfunction. We don't really know what those are. We don't know if they would remove the nerves, they wouldn't remove the nerves. But those are the sorts of things that you sort of, you have to dig down into with the urologist and then with whoever you're talking about to see if there is marginal benefit to you, and then weighing up that the marginal benefit with the marginal cost. And in my own case, I didn't want to roll the dice for 30% success. I didn't think it was worth it. And that's why I really wanted you to do the nomogram as soon as you could, so that, and certainly before you talk to the doc tomorrow, because that will give you a really good basis for discussion with the medical oncologist.
Mm-hmm. Now, isn't there, let's say, using a number of 15% chance of no recurrence, what's the odds of radiation therapy, say SBRT, achieving a similar ability?
Well, it's not actually saying that. What it's telling you is this. It's not telling you 50% chance of nailing the disease. It's saying to you there is an 85% likelihood that you will need hormone therapy and radiation in addition to the surgery.
Oh, okay. Oh, okay.
That's what it's telling you.
This is Jay. If I could speak up, I wrestled with this issue as well, and I ultimately came down on the side of radiation and ADT as opposed to surgery. But I just wanted to sort of perhaps clarify what Rick is saying, is that if those were exactly my numbers. My nomogram said 85% chance that I would not be cured by surgery or radiation. That the nomogram is built around surgery, but you could just, for argument's sake, say that they're comparable in terms of you can just pick one or the other and you're going to get about the same results. The difference, though, is that if you were to, Rick is saying, what if you had radiation and then added the surgery? People don't generally do that. They generally do the opposite. They choose the surgery, and then they end up saying, well, that didn't work. It's back. I got to do the next thing, which is ADT and radiation. And you end up getting both insults as opposed to just the one insult that generally takes care of it. So it's if you look at it from that perspective, that you're very likely to need to have radiation regardless, that just go ahead and use that as your main tool, and that then you won't end up having to do the surgery because it adds such a tiny bit of possible benefit, and yet it brings with it, like my father had a hard time being able to control urination, and then as he got older, it got worse. So that's something that he has. I've witnessed that that's a bad situation.
John?
So I wanted to clarify that's all.
And
John, do you have any symptoms right now? Any urinary symptoms like retention or frequency urination and so forth?
No, it's. I mean, it's fairly regular.
Okay.
I can chime in to say that I went through the surgery first. I wish I would have known what I know now, and I would have skipped the surgery and gone right to ADT and radiation, which is where I'm at right now, 1 year post-surgery. So I did go through all the issues with the surgery. Luckily, the cognizant issue was very quickly. I did my exercises before. I was in good shape, and I was able to get that back in control a couple days after the catheter came out. The ED is a continuing issue. So had I had to do over again, I would have done this a year ago and skipped the surgery and all of the everything that went with it. So that's just an advice from someone that's been through it. I'm a little bit less Gleason. I'm 4'3", but nonetheless, I'm here again and starting the ADT and radiation route right now.
So
David Muslin would say the same thing. I did the same thing. If I had an opportunity not to do the surgery, I wish I would not have done the surgery, but that's passing. If we can help others, that's great. But I agree with the last gentleman who just spoke. I think that was John.
And I sort of, I was using my words loosely. I mean, I didn't mean to say that you would do the radiation hormone therapy and then do surgery. I mean, but I was trying to express what I was trying to express. Jay expressed better. So
Now,
I think.
can I ask one question?
Yes.
So some refer to the best therapy as the sort of a trifold where you do ADT, radiation therapy, and then you do brachytherapy.
Yes.
Does anyone have an opinion on that?
Well, when we say radiation, we're using it very broadly. So radiation can include IMRT or PBRT, SBRT, which is the more focused stereotactic body radiation therapy, and it can include different types of brachytherapy. So in my own case, I did seeds and IMRT. And that would almost certainly be your situation, some type of brachytherapy or SBRT, and then IMRT or PBRT to the whole pelvic girdle. So we are really including brachytherapy, and in this case, with the amount of cancer, it's almost certain that they would use high dose radiation, which is where they insert radioactive rods into the prostate and then withdraw them. They insert them, leave them for a few seconds, and then withdraw them rather than the permanent seeds.
Right. They were recommending doing SBRT high dose over 10 days.
Yeah, so again, I mean, I think you have to, one of the questions is, and the research is to look and see whether the results from SBRT are better than the results from brachytherapy. The person who could tell you in a heartbeat is Alan Idell. And I can probably connect you to Alan and he'll know if any studies have been done.
Oh, I would love that. I would love that.
Okay, well, I'll make a note. I'm put a note by your name because he'll know if studies have been done yet comparing SBRT plus IMRT plus hormone therapy to high dose brachytherapy plus IMRT plus hormone therapy.
Okay.
He will have an opinion on that. And you know, I don't. I can tell you that for me, it was successful. I mean, I have a durable remission from what I did. And that's why I would do it again. I need to leave a little bit of time for Russ Smith here. And I apologize to everybody that we have to finish on time today. But John, you know, call, you know where Ken is. You can call me up anytime in the next few days. Who is it that you're seeing tomorrow? Is it Dr. Singh?
I was hoping it would be Dr. Singh, but I've got Cassandra Moore, who's an oncologist, hematology and oncologist, and I guess may not be the I forget how you pronounce the term for it.
Here's my issue with that. You know, to ask her the question about the advantage, if she's just a general med-onc or a hematological med-onc, she's not going to have the background, the knowledge. She won't have seen enough people to be able to answer the question. I mean, I do think if you're going to see a medical oncologist, you need to see a GU med-onc.
Okay. All right.
I mean, that would be my 2 cents. And anybody else want to chip in quickly before we finish up with Russ?
Yeah, John, I would second that. I would insist with Mayo, they'll try to hand you off to someone else, but I would just say no. I want to see Singh. Don't let them hand you off. So I would insist, and they'll let you see him.
All right.
John, this is Peter. You can always write to me. I had the opposite experience that most guys have had. I did surgery first, and then I followed up with radiation. I'm also a Gleason 9. I had an unusual situation, and it tackled it. So I'm thankful that I did it in that way. But I'm one that did it. You can always talk to me about it.
Okay. Thank you.
So you've got at least three guys on this who did surgery and followed up with radiation and hormone therapy, 2 of which weren't so happy with that decision in retrospect, and 1, Peter, who really needed to do it that way because he was suffering with strictures and blockage. And then you've got a couple of us on here who did it the other way. I was successful. We're hoping that Jay is going to be successful. We don't know yet because it's too early. But I think at the end of the day, you have to think about this in terms of what is the marginal cost to me of doing the surgery in addition, and what are the marginal benefits to me of doing the surgery in addition, starting with the surgery and then most likely having to go on to the radiation and hormone therapy. And only you can weigh that one up, John.
Sure. Thank you.
Okay, Russ, you're going to close us out tonight.
Yeah, it will be quick because I can pick this back up on Thursday night, but I'm meeting with my RO tomorrow, my local Dana-Farber, to plan out the next, planning out the radiation portion. And I guess the only thing I got to put out there real quickly is anything out of the ordinary I should ask NAB tomorrow while I'm there that you guys would advise.
Okay, so those of you who have had to do salvage or adjuvant, either adjuvant or salvage radiation, what would you suggest to Russ as being the important issues to cover when he meets his doctor?
Well, they do the public girdle as well as, I guess they're going to do that anyway. They're going to salvage radiation. But just make sure that they go up in this area.
Good point. Yeah. Did you catch that, Russ?
I did.
Yeah. So yeah, be sure they're gonna cover the pelvic girdle. Anything else that those of you who have done radiation subsequently feel that that Russ should address? David Muslin, is there anything that comes to your mind?
No, I had ulcerative colitis that was in remission before I did radiation. Nobody talked to me about that, and it's caused a lot of upheaval post-radiation. So hopefully you haven't had any inflammatory bowel disease. If you did, you should talk about it.
Good.
Okay. And this is Jay Mills. If you haven't had a colonoscopy in a while, get that done beforehand, so that you don't have anybody roughhousing with that while it's fragile. That was.
Yeah.
I know that can be dangerous.
Jay, that's such a good point. I mean, I had my doc, who happens to be the same as Jay's doc, stopped me from getting a colonoscopy for like 5 years. after I'd had the radiation because I had some issues. And he didn't want me to risk a fistula. So yeah, if you, how old are you, Russ? 56?
58. My last colonoscopy was like 3 years ago, and I was squeaky clean.
Okay, well, you might want to ask the radonc tomorrow whether you should get a colonoscopy before you start the radiation. That's a great point to bring up, Jay. It's definitely worth thinking about. Anything else anybody wants to, do you have any urinary issues right now, or are you back to 100%? Russ?
Oh, I have no urinary issues whatsoever.
Great. Okay. And have you ever had any hernias?
Only when I was 2 years old.
Okay. So you don't have any mesh in your body?
No, I take that back. When they did my radical, they fixed a navel hernia.
Okay. So you might want to raise that with the doc too. Just let him know. Anything else anybody can think of that should be raised? I mean, stuff like diet and exercise will help you with as you go through. We've just from our experience. But are there any other medical issues that anybody can think of that we should be talking about? Okay, well, we'll call it a day. The next meeting is Monday. No, wait a minute. Yes, where are we? Today is the 10th, the 16th, Monday the 16th. Thank you, Peter. Monday the 16th will be the next meeting, and we'll send out our notice as usual. And just keep washing your hands, and if you don't stop going to the gym, but wipe the equipment down before and after, before for yourself and after for the next person. And I think that's about it. And Ken and Peter, I'll see you in about 25 minutes. And Len, sorry. Yes.
Nothing.
Okay.
Good night, thank you, guys. Take care.
Thank you. Thank you,
Good night,
everyone.
Thank you. I must have been an hour late.
Yeah, me too.
Here's this.
Me too. Good night, everybody. I just got on.
Sorry, I didn't acknowledge you.
No, I just got on recently. My girlfriend reminded me. Wasn't it 6, not at 8? I said, oops. All right. Good night, everybody.
Good night. Good night. Bye.